This conference will now be recorded.
Okay, well, this is Joe Gallo, and I've got a couple of quick administrative topics for you before we kick off the program. As you probably just heard, we are recording this session because we do have a number of people who either can't join in or want to come back and see the replay of it. I ask that everyone please stay on mute while you're in this session. You may optionally turn off your webcam because it will get, otherwise the screen will get a little bit crowded, but I'll leave that up to you. The participant, each of the participants will be able to handle that. If you're not familiar with the format, at the top of the screen there is a bubble. That is the chat bubble. That is where you would click open the chat to put your questions. You can start entering questions at any time through the presentation. Then members of the moderating staff will actually take those and bring them together and present them to our guest afterwards. I understand that the presentation is going to take about 40 minutes, so to give you some idea, and then we'll have at least another 45 minutes on top of that to handle the Q&A.
Joe, can I just butt in 1 second when you talk about the moderating staff? I think everybody here in the group would like to wish our absent moderating staff member who's recovering from a radical prostatectomy yesterday a very, very successful and quick recovery. So Elliot, when you listen to this, if you listen to this, we're all thinking of you and we miss you.
Good point. Good point.
I should add then, we were going to mention that later, but I checked in with Elliot and he said he'd be happy to hear from anybody. So I'm going to put his email address in here.
Thanks.
So anybody that wants to give him good wishes, he's been walking laps around his living room trying to dislodge some CO2 gas, and but he seems to be doing pretty well.
Right.
Okay, I guess that part of it's pretty good. The session will now get underway. Howard is going to be our primary individual to work with Darryl Leong. So Howard, over to you.
Okay. Yeah, I'm Howard Walensky. I'm another one of the moderators. This is primarily an active surveillance group, but in talking to Darryl, we decided to expand. So he has expanded his presentation, and we'll expand our questions and answers afterwards. I'll just give a little bit of background on Darryl, and then away he goes. Dr. Leong graduated with honors. We would have accepted no less, and Dean's listing from the University of Adelaide Medical School in Australia. He completed his internal medical and cardiology residency at the Royal Adelaide Hospital before completing a PhD, Master of Public Health, and a Master of Biostatistics. He then undertook postdoctoral fellowship at Leiden University Medical Center in the Netherlands, and a further fellowship at McMaster University in Hamilton, Ontario, Canada. He accepted a faculty position with the Division of Cardiology at McMaster University, where he is Director of Cardio-Oncology and Associate Professor of Medicine. His research has been published in all the major internal medical and cardiovascular journals. His research is supported by a variety of organizations, including the Canadian Institutes of Health Research, Canadian Cancer Society, the Health and Stroke Foundation of Canada, Prostate Cancer Canada. There's a long list. He is leading one of the largest studies to examine cardiovascular disease in men with prostate cancer. It's called Radical PC, all caps. And I'd say take it away, Darryl. And at the end, maybe you could put a plug in for this new research that you're doing.
Well, thanks
So
very much
Darryl,
for
the
the
floor.
kind. Certainly. Thanks very much, Howard, for the kind introduction, and thank you to you and Joe for this invitation to speak with folks tonight. It's a real pleasure and a privilege. So we'll get underway. I guess the meaning behind this somewhat obscure title of my presentation is going to become apparent as we make our way through it. But what we'd like to speak to is predominantly regarding active surveillance and how you can have your cake and eat it too if you're on active surveillance, what that actually means. So I haven't got a disclosure slide. I should have included one, and I should disclose that I am on advisory boards for Ferring Pharmaceuticals, who manufacture Darryl. But the objectives of the presentation tonight are really to review the survival expectations for men with prostate cancer and who are eligible for active surveillance, to understand what we mean when we doctors talk about competing risks, and to discuss strategies to reduce the main competing risk, I would argue, for men with prostate cancer, and that is cardiovascular disease. So this is a graph that some of you may have some familiarity with. Just to orient you, on the vertical axis, you see time in years after somebody enters an active surveillance strategy for prostate cancer. And on the vertical axis, you see the number of patients who've essentially died. So at the beginning of the graph, on the left-hand bottom corner, you see that no one's died because all 5,302 participants entered the research at this point. And then over time, unfortunately, people do die. And I draw your attention to the blue line here, because this represents the people who died as opposed to people who are lost to follow-up or people who withdrew from active surveillance. And what you can see is that over time, there is this gradual but inevitable increase in the number of people who died, such that when we get to about the midpoint of the graph, so after about 5 years of active surveillance, at that point, about 5% of individuals on active surveillance will have died. And as we continue on to about 10 years after entering active surveillance, about 15% of individuals on active surveillance will have died. And so I think this is actually a good news story, because these sorts of numbers, while we obviously want to minimize mortality, are not extraordinarily high, but the implications of this are going to be apparent on the next couple of slides. So this is, again, research that comes from Dr. Klotz's group at the University of Toronto in Canada, looking at nearly 1,000 of his patients who went on to active surveillance. And what you see in the left-hand graph, again, the horizontal axes in both graphs represent time after entering the study. The graphs are sort of flipped around so that everyone starts off in the study at the beginning, hence 100% of people are alive when they enter the study. And then over time, as the years progress, people do die, such that at about 10 years of follow-up, 20% of people had died and 80% were still alive. And by 15 years, 62% of people entering active surveillance were still alive. So this is overall living and dying on the left-hand graph. What's shown on the right-hand graph is the same information for prostate cancer-related death. So you can see that over time, a proportion of people die of prostate cancer. But what is really striking is the huge gap between the number of people who die of prostate cancer and the number of people who die of anything at all. And so the question is, if as a man with prostate cancer on active surveillance, you're not really dying that frequently of the prostate cancer, what are you dying from? This research is supported by yet another study of over 1,000 people, looking at, again, the cumulative incidence over time on this horizontal axis here of death due to any cause in the dotted blue line versus death from prostate cancer in that mustardy colored yellow line. And what you can see is that over 10, 15, 20 years, a gradual increase in the proportion of people who died, which is, one of the hard truths about life, is that death is inevitable. But you see an ever-widening gap between the number of people who died and the number of people who died of prostate cancer on active surveillance. And so again, we're left with this question: what is filling this gap and accounting for all these deaths in men with prostate cancer, but who are not dying from their cancer? When I started at McMaster, I undertook this analysis of the SEER registry from the United States that some of you may be familiar with. The SEER registry collects data from at least a dozen different institutions and catchment areas within the US for various types of cancers, prostate being one of them. And shown here is a similar sort of analysis to what you've seen. So on the a horizontal axis, we see the number of years after a man is diagnosed with prostate cancer. And in these colorful bands, we see the cumulative incidence of death of various different causes. So in the sort of mauve color or violet color on the bottom, we see the cumulative development of prostate cancer death over the years. And bear in mind, this is all men with prostate cancer. This is not restricted to active surveillance. And in this sort of salmony colored curve, we see the number of individuals or proportion of individuals dying from cardiovascular disease. And what's really striking is that the longer you survive after your diagnosis with prostate cancer, the more and more likely you are to die of cardiovascular disease, such that at a certain point, it looks as if you're more likely to die of this cardiovascular disease here than you are of prostate cancer at the bottom, because the thickness of the curve is greater in the salmon here compared to this violet color. And so this is what drew my attention to cardiovascular disease in men with prostate cancer when we started on this journey. Here's a little further analysis that I undertook of the SEER registry. This time on the horizontal axis, we see the number of years from your diagnosis with the prostate cancer. And on the vertical axis, we see the likelihood that you would die of cardiovascular disease within the next 10 years. So you can see that at the time of men with prostate cancer being diagnosed with their condition, 0.15 or 15% of individuals will die of cardiovascular disease in the next 10 years. If you survive the first 5 years of your prostate cancer diagnosis, I think someone is unmuted there because I hear a loud echo. I don't know if everyone can mute themselves. Thank you. So if you survive 5 years from your prostate cancer diagnosis, you see that the subsequent 10 years, you have about a 21% risk of dying of cardiovascular disease. And the longer you survive after your prostate cancer diagnosis, the higher that risk of dying of cardiovascular disease gets. You might ask what this red line here is. This is a 20% 10-year risk of cardiovascular disease. And I draw it here because for cardiologists, we consider anyone who has more than a 20% 10-year risk of cardiovascular disease to be at relatively high risk of cardiovascular events. So that's an important landmark or milestone for us there.
This media landscape, there's one channel.
I think Horace has come off mute, so it'd be appreciated if you could just mute yourself there, Horace. Just thank you. So we've been talking about cardiovascular disease as this competing risk, something that folks can die of that is not actually their cancer. What is cardiovascular disease? Cardiovascular disease refers to any disease of one of the large blood vessels in particular that supply vital organs of the body with the blood that the organs need to survive. And so cardiovascular disease can affect the heart arteries or coronary arteries, and we're going to discuss this in a little more detail. But equally, even though I'm not going to discuss them in as much detail, vascular disease can include disease of the blood vessels to the brain, manifesting obviously as a stroke, and can also affect the vessels supplying the legs with blood, which can cause peripheral arterial or peripheral vascular disease, which is also potentially a life-threatening form of cardiovascular disease. But for the purposes of this presentation, we're going to focus mostly on cardiac or heart-related cardiovascular disease. But before we do that, why is cardiovascular disease important? This is an analysis that Dr. Dagenet and I undertook of a large cohort of men, over 100,000 individuals from about 21 countries around the world, looking at the different causes of death and which ones were the most common. What we found in this analysis of the PURE study was that worldwide, cardiovascular disease remains the most common cause of death, followed by cancer in second place. And so it's unsurprising that if you don't die of your prostate cancer, especially if it's at an early or low risk stage, then it's therefore likely that cardiovascular disease is going to be an important health concern for you. So just to drill down a little bit more onto cardiac or coronary artery disease, broadly speaking, and I'm going to assume that folks don't have a lot of familiarity with cardiovascular disease. I may be wrong for many of you, but we divide coronary artery disease, broadly speaking, into two different types of syndrome. First, we have stable coronary disease, and the typical pattern is someone who develops some chest discomfort when they're exerting themselves. They report to a physician, get referred to a cardiologist, and get something like a stress test. And that's how their coronary artery disease gets identified. And so while this is important, this is not a medical emergency necessarily. This is something that would typically get dealt with on an office type of basis. At the other end of the spectrum, we have what we refer to as acute or unstable coronary disease. And that is your typical myocardial infarction or heart attack, where you get severe chest discomfort occurring often at rest. Ideally, an ambulance, EMS would be called, and this would be brought as an emergency to the hospital, and procedures be done urgently to try and resolve this situation. And so in the next couple of slides, we're just going to walk through the differences between these two types of coronary artery disease. Shown here is a schematic diagram of a coronary artery cut in a cross-section longitudinally. And what you can see in this diagram is a gradual buildup of cholesterol plaque. And as you can appreciate, as that plaque builds up, the actual lumen of the artery down which blood normally flows to supply the heart with blood gets narrower and narrower, to a point where when one has to exert and the heart needs more blood to meet its demands, not enough blood can get through this narrowed segment. And that's why folks get angina, or as in the United States, you'd pronounce it angina. And that is typically presenting with chest discomfort or chest pain with exertion. Now, for reasons that we don't completely understand, in some individuals, this buildup of cholesterol, this plaque in the coronary artery, can rupture or develop a tear in its surface. And whenever anything exposed to blood occurs as a result of a tear in tissues, blood wants to clot. And that's the mechanism by which we don't bleed to death when we cut ourselves. But unfortunately, when blood clots in a blood vessel that's 2.5 millimeters in diameter, there's a tendency for it to block it off. And when that happens abruptly or acutely, this is what causes an acute coronary syndrome or a heart attack or myocardial infarction. And to prove that I'm not just making this stuff up, here are some autopsy specimens from firstly an individual with a coronary plaque, and you can see in this cross section here the remaining open lumen of the coronary artery. So blood flow is clearly restricted to this lumen. And down below it, you see a coronary artery with plaque, but where there's been a rupture of the plaque and a blood clot has developed and is now superimposed on that plaque and completely blocks off blood flow down this artery. And so this is a real pathological representation of what I showed you on the previous slide. So what predisposes folks to getting acute coronary syndromes or myocardial infarctions? I mean, these are, like I said, one of the major and possibly the most common cause of death in the general population worldwide. Well, our group at McMaster has done a lot of research into what causes cardiovascular disease, myocardial infarctions, and we estimate that about 70% of the risk of having a heart attack in the general population can be explained by these 10 potentially modifiable risk factors. And I'm sure that many of you would be familiar with a lot of them. You know, smoking is bad for coronary arteries, as is diabetes, hypertension, obesity, excessive alcohol use, especially when it's consumed in a heavy sort of episodic manner, psychosocial stress, low fruit and vegetable intake, low physical activity, and high cholesterol levels. And most recently, we've identified low muscle strength as an important risk factor for heart attacks and cardiovascular disease. Why I show this list though is this. Many of the risk factors for cardiovascular disease also happen to be either risk factors for prostate cancer or risk factors for high-risk prostate cancer, or can be caused by androgen deprivation therapy. And so you can see that the average individual with prostate cancer may well have, at some stage during their course, a lot of the risk factors that predispose them to also developing a myocardial infarction. So I mentioned before that as a physician, we consider a patient to have a high risk of cardiovascular events if that risk is 2% per year or more. To give you an idea about where men with prostate cancer stand, this is data from US veterans, I think about 5,000 US veterans, looking at the risk per year of them developing a myocardial infarction, so a heart attack, or sudden cardiac death, or a stroke. And this particular part of the analysis was confined to folks not treated with androgen deprivation therapy. So what you can see in the right three columns, if you were to tally this up, the risk of developing one of these major cardiovascular events in men with prostate cancer not on ADT is probably over 2%. So over that threshold that we consider to be at high risk. And in fact, if you look at folks treated with a GnRH agonist as androgen deprivation therapy, that risk seems to be higher again and into the very high sort of a territory. And in fact, many folks now have done research into whether androgen deprivation therapy use is associated with an increased risk of cardiovascular disease. What this is a meta-analysis, so a summary of, in this case, 6 different observational studies examining this relationship between ADT and no ADT. So what they basically did in all these studies was took an administrative set of data of men with prostate cancer, tallied up those who had received ADT and those who had not, and then tallied up how many had developed cardiovascular disease and how many had not. What they found was there was a 17% higher rate of cardiovascular disease occurring amongst men treated with ADT as compared with men who did not receive it, when you summarize all of these data from thousands of men with prostate cancer. And it was really data like this that led to the initial black box warnings about some of the potential cardiovascular risks associated with androgen deprivation therapy use. So that, I guess, is concerning. But then there was this data published by Dr. Nguyen and colleagues from Boston. And they looked at randomized trials this time of androgen deprivation therapy. So I'm sure, again, many of you will be familiar with this concept of a randomized trial. In it, a patient gets offered on a random basis either a medication, in this case ADT, or some sort of control group where they either, in this case, did not receive ADT, or they were instructed to delay the use of ADT at least until there was disease progression or some other later point. So basically, half of these individuals got ADT up front, the other half didn't get ADT, or they got it sometime, months to years, after the other group that they were being compared with. What you can see in this analysis is that there was essentially no difference in the risk of cardiovascular death amongst people randomly allocated to get ADT as compared to those who did not receive ADT up front. And so you can see here in this bottom line that 255 out of 2,200 ADT recipients died of cardiovascular disease, and 252 out of 1,941 control participants died of cardiovascular disease, and this was really quite neutral. So how do we kind of resolve this? That one set of studies and evidence seem to suggest that men with ADT are at higher cardiovascular risk, and another set of studies suggests that it isn't the case. That's why we set out to do some further research to understand what's going on a little better. One of the main limitations of the research that I showed you in the past couple of slides is that they were limited in how well they could characterize and measure cardiovascular risk in the participants in these various studies. They weren't designed necessarily, these studies, to look at cardiovascular disease. But as a cardiologist, that's obviously our interest, and so we pay much closer attention to certain factors. So the Radical PC study is a large study, thus far recruiting about 2,500 Canadian men, and we've just recruited our first international participant in Turkey, and we hope to expand to a number of other countries. What one of the main aims of Radical PC is to examine the relationship between hormonal therapy and cardiovascular disease events. What I can share with you are some of the characteristics of these Canadian men with prostate cancer. So on the vertical axis here, you see the proportion or the percentage of men in our cohort who had any of these cardiovascular risk factors shown on the horizontal axis. On the left-hand side, you see that it's the proportion of people with a Framingham risk score of more than 17. Now, to give you some idea what that means, that Framingham risk score is associated with roughly a 30% 10-year risk of future cardiovascular events. So we would consider people with a Framingham score over 17 to be at quite considerable risk of developing cardiovascular disease in the future. What we found was that at least a third of men with prostate cancer are at this so-called very high cardiovascular disease risk level. And you can see in these other columns just why this risk is so. So about 2/3 of them had relatively high cholesterol values. Over half had smoked or were current smokers. Nearly half had hypertension, and at least a third were obese, as well as nearly a fifth having diabetes. And when you look here at past medical history, we see that at least a fifth of individuals with prostate cancer have a past history of cardiovascular disease, including a previous heart attack, cerebrovascular disease or stroke, atrial fibrillation, heart failure, or peripheral arterial disease. So this really tells us that in general, many men with prostate cancer already exhibit the signs that they are at risk for or have significant cardiovascular disease, and therefore this is likely to be something that we should be paying close attention to. This is some work that we recently had published in one of the European Heart Journal subjournals. It was led by a fellow of mine, Dr. Felipe Sierna. And what we did was we looked at the comparison between GnRH agonists, which you'll be familiar with as a form of ADT, with the GnRH antagonist, the most common of which is Darryl, currently on the market. However, I'm sure many of you will now have heard the news that there is another oral GnRH antagonist called Relugolix that has been approved by the FDA. And so what this represents is a summary of the data comparing the antagonists with the agonists in head-to-head clinical trials for the outcome of cardiovascular death. What we found when we pulled the results is that there was a 54% reduction in the risk of cardiovascular death associated with the use of one of these two GnRH antagonists when compared with a GnRH agonist. Now, those of us in the field, and perhaps many of you, may have been aware of this sort of data percolating around for quite some time now. And while it sounds very encouraging and is potentially good news, you might also be wondering why GnRH antagonists like Relugolix have not hit prime time. Why don't we use it universally if indeed they are so effective at reducing cardiovascular death? In my opinion, here is one of the reasons why. In part of our analysis, we evaluated the quality of the various trials I showed you on the previous slide. And when these different measures of study bias are evaluated, we give them a green circle if they've done a good job at minimizing bias, a question mark if we're uncertain from the trial reports, and this minus sign if we feel that the trial is at a high risk of bias and therefore perhaps unreliable findings. And what we found was because of the nature of the design of all of these trials, all of them essentially had high risks of bias in at least one of the fields, and most often in a couple of fields. And for that reason, we felt that there is insufficient evidence at this stage to be highly confident that the GnRH antagonists do reduce the risk of cardiovascular death as compared with GnRH agonists. I'm reassured that the FDA came to the same conclusion when it came to the approval of Relugolix. they equally did not feel that the evidence I presented to you on the previous slide was sufficient to have on the product monograph that relugolix reduces the risk of cardiovascular events compared with GnRH agonist. And so that's really where my take on the field of antagonist versus agonist is. For the remainder of the slides, I'm going to switch track a little bit and talk then about how we can prevent cardiovascular disease, especially in individuals who do not have any known cardiovascular disease, because I think people who, with a previous history of heart attacks, myocardial infarction, coronary bypass surgery, that's a talk unto itself because there are many different therapies available in that space. I'm going to focus on the individual who does not have known cardiovascular disease. And with these 8 simple steps, I think we can encompass some of the key issues pertaining to these individuals. So the first item is that physicians are recommended to use a risk prediction tool like the Framingham risk score that I mentioned before. And this is what the Framingham risk score takes into account. A number of those cardiovascular risk factors I showed you on an earlier slide, including an individual's age, their cholesterol levels, especially high density lipoprotein cholesterol, their blood pressure, smoking status, and diabetes. And what can simply be done, and this is available online as an online tool or calculator if you wanted to do it for yourself, is we simply ascribe a number of points depending on where each individual scores with regards to each of these cardiovascular risk factors. We then tally the score up and match it, the total number of points here on this part of this, the table, with their 10-year risk of future cardiovascular disease. And as I mentioned to you before, if that 10-year risk exceeds 20%, so in this sort of darker part of the box, that's a level of risk that we would consider high risk. So identifying people at risk is the first step. The next step, I think, is to talk about risk factors then and how we could reduce them. A lot of talk is made on healthy diet and what constitutes a healthy diet. And unfortunately, in my opinion, there's a lot more talk than there is definite knowledge. Here's my take on what I think constitutes a healthy diet. It's typically one which is high in fruit, vegetables, nuts, and whole grains, and relatively low in refined sugars and carbohydrates, and in particular sugary beverages. Now, you will hear many different variations and many different types of diet out there, and I'm sure there will be questions about diet, but my simple message when it comes to diet is that the quality of the evidence to provide really good quality recommendations about what constitutes an ideal diet, especially for the man with prostate cancer, I think there's still a lot of uncertainty in this field. And so I think broad brushstrokes and simple recommendations like this are probably the most sensible, along with saying that most foods in moderation are probably a reasonable strategy to adopt. Unlike diet, I don't think there's as much controversy about exercise, and the current recommendations for most international guidelines about how much exercise would suggest that we do about 150 minutes per week of moderate intensity exercise. And when my patients ask me what is moderate intensity exercise, I give them a guidance that if, let's say, you do walking or even jogging for exercise, if you can talk in full sentences to someone walking or jogging with you, then you're probably not doing it intensively enough. If you can't get out more than a word or two at a time, that's probably too intense. And what you want to be aiming for is about 4 to 5 word sentences while you exercise. And so that might be a pretty crude guideline as to what constitutes moderate intensity exercise. Now, you've also probably heard, especially those of you with diabetes, about different management strategies for diabetes. Diabetes is one of the major cardiovascular risk factors. And for the longest time, we did not have any evidence or science to prove to us that any particular treatment for diabetes would reduce the risk of having a heart attack. That said, for men with prostate cancer, there has been a lot of support for the use of metformin. And this support is really driven by the fact that metformin can reduce obesity, so can reduce adiposity and fat tissue, and appears to reduce impaired glucose metabolism in folks on ADT. And so that was the reason why a lot of people will promote metformin use if you have diabetes and you have prostate cancer. Now, just recently, there is a new class of diabetic drugs called the SGLT2 inhibitors, and I've listed the three main examples of SGLT2 inhibitors there on the slide. This family of diabetic medications is the first to very conclusively demonstrate a reduction in the risk of cardiovascular death, heart attack, stroke, and heart failure across a broad range of people with known cardiovascular disease, with or without diabetes. And so these drugs are, I think, going to be hugely successful at reducing the burden of cardiovascular disease in the general population. And there's no reason to think that they wouldn't be just as effective for men with prostate cancer. In fact, they've even been shown to reduce the risk of deteriorating renal function, kidney function as well, in individuals with some degree of renal impairment there. So I think this is really a space to keep your eye on, and I prescribe SGLT2 inhibitors for a lot of my patients who are at high risk of developing cardiovascular disease. A lot is also said about aspirin, and a lot of my patients really think that they should be taking aspirin as primary prevention, even though they've never had a heart attack, never had a stroke, never had a stent or a coronary bypass operation. And until recently, that may have been something that cardiologists would endorse. This thinking has recently been called into question. So there have been a couple of very large trials, including data from the United States, to suggest that if you do not have cardiovascular disease, that the benefits of aspirin may be negated by some of its side effects, and overall, it may not result in any reduction in the risk of death. And people think that taking a baby dose of aspirin, 81 milligrams a day, is a safe thing to do. What perhaps gets underemphasized is the fact that aspirin can cause bleeding, and in particular, bleeding from stomach ulcers. And it may be this that leads to the harmful effects that outweigh the 10% or so benefit aspirin has at preventing heart attacks and cardiovascular disease. A statin is a drug, though, which I think is likely to be beneficial in the primary prevention of cardiovascular disease. Statins have been shown amongst thousands and thousands of individuals with and without a history of vascular disease to reduce the risk of cardiovascular death and major adverse cardiovascular events. So in this figure here, in the bottom panel, we see the overall effects in about 25,000 individuals of taking a statin versus not taking a statin or less intensive cholesterol lowering therapies. And this relative risk of 0.79 here indicates that for every 1 millimole per liter reduction in LDL cholesterol associated with a statin use, there is a 21% decrease in the risk of major adverse cardiovascular events. And this is true whether or not you have a history of vascular disease. And so it's data like this that has led major institutions like the American Heart Association here to suggest a somewhat complicated algorithm for considering statin use for the prevention of cardiovascular disease. Now, I don't want to go through this table and slide in a huge amount of detail. Perhaps this talk is being recorded. You can take your time to peruse the different arms of this slide in some more detail and figure out where on the slide you fit. But this provides clinicians and patients with an algorithm that I think is quite reasonable to follow to firstly determine what the cardiovascular risk level is and what course of action might be undertaken to reduce that risk. And as you can see, in many people whose risk is moderate or higher of developing cardiovascular disease, a statin may be useful to lower that risk. Lastly, my last comment is about blood pressure. And I think there is sufficient evidence to suggest that if you have high blood pressure, that a target blood pressure of less than 130 on 80 is highly desirable. And this here are recommendations again from a guideline statement for the American Heart Association suggesting the thresholds of blood pressure and what actions should be taken if blood pressure exceeds these thresholds to minimize cardiovascular risk. So I guess to conclude this presentation, what did I mean by the title, Can You Have Your Cake and Eat It Too? If we think of active surveillance as a means to avoid prostate cancer treatment related complications, if we consider that the cake, you're only going to benefit from the cake if you can eat it. And likewise, you're only, I think, going to get the full benefit of surviving without the side effects of prostate cancer therapies if you can avoid dying from the major competing risk of prostate cancer. And I think it's pretty clear that that major competing risk is cardiovascular disease. And for that reason, I think that to have your cake and to eat it as well, you need to also, in addition to thinking about your prostate cancer and its management, think about how cardiovascular disease could be prevented and treated. And so on that note, I'd just like to acknowledge Prostate Cancer Canada and the Canadian Cancer Society who support our prostate cancer research, as well as my team in the project office at Radical PC and the 2,500 participants, mostly in Canada, who have been involved in our research to date. Thanks very much. Happy to open discussion.
Well, thanks, Darryl. This is Howard again. And there was a recent study by Dr. Justin Gregg from MD Anderson that says that it looks like there's some benefit to the Mediterranean diet. And I can tell you, as somebody who has both prostate cancer, diabetes, and it seems like everything else, I go to a cardiologist and I go to a urologist. The cardiologist seems much more confident in his dietary recommendations. He said, he strongly recommends the Mediterranean diet, which is what Dr. Gregg was giving a boost to. The urologists, not so much. They seem to be waiting for more evidence. So I'm wondering, what is the Mediterranean diet, and are you any more confident than my cardiologist?
Yeah, great question, and it's a common one that we get. I think it's useful to first of all discuss the evidence and how the evidence is generated that supports our various levels of confidence. The best level of evidence and the most concrete scientific proof we have that anything works is a randomized trial. In a randomized trial, we randomly allocate half of the participants to getting some form of intervention. In this case, it's the Mediterranean diet. And in the other half of participants, they randomly get a placebo if it's a drug trial. Or in the case of a dietary study, you obviously can't survive on placebo alone. And so typically it would be your usual diet. The problem with dietary trials, as opposed to drug trials, where it's very easy to present patients and participants with a medication and it's covered in a capsule, so no one knows whether it's the active drug or it's a placebo. The difference with dietary trials is that you can't disguise what participants are getting, and you're in fact very limited in actually controlling and knowing what a participant is actually putting in their mouth and eating. In a drug trial, you can count the number of capsules of the drug that participants take every month or at the end of the trial. And so you know whether or not they've taken the study drug or not. In a diet trial, if someone decides that they're going to go out and feast on fast food, you actually don't know that, and you have little ability as a clinical trialist to control that. As a result, the results from clinical trials are often a little bit harder to be confident about than classical pharmacological trials. So that's the first comment I would make. If food trials and diet trials are very difficult to do, then how do we know, or how do we think we know, that certain foods are better than others? It comes from what we call observational evidence. In observational studies, we don't randomly allocate people to get one food or another. We simply observe or document what food they report to us that they eat, and we observe over a period of several years what happens to them. And we see whether or not certain foods are associated with better outcomes than others. And so, a lot of the evidence to suggest that the components of a Mediterranean diet, like olive oil, for example, or nuts and legumes, are healthy for you, come from these kind of observations, that people who live longer typically eat more of these kind of foods. The problem with observational data is that we can't always account for what goes along with eating those kinds of foods. Maybe people who eat more olive oil and have more nuts are more health conscious, and maybe they pay closer attention to exercise They do other things that are good for their health, especially things that we can't measure, we don't know about. And perhaps it's those other healthy things that is actually driving the benefit that we observe amongst people who have, more olive oil and more nuts, etc. So that's one of the inherent limitations of this so-called observational data. And unfortunately with diet, that's the main way in which we derive our evidence. So that's a very circuitous and complicated answer to your question. But the shorter answer is, how confident am I in the Mediterranean diet, a diet which is, like I said, rich in olive oil, nuts, legumes? I would say that there is certainly no indication that it's harmful for you. So that's the first thing. And if it suits your palate, then a Mediterranean style of diet is certainly a very fine one to have. Is it likely to be more effective than, say, a statin, for example? I think that's unlikely. Is it likely to have some more modest benefit? I think that's quite possible. So I do encourage patients to have, a Mediterranean style diet. I think it is a very sensible dietary choice. But of course, there are a whole lot of other factors that go into diet. Diet is, we don't eat to stay healthy. We eat for a whole range of reasons, some of them social, some of them simply enjoyment, as well as satiety. And I think all those factors sort of need to play in, as does cost. Some of the components of a Mediterranean diet, like nuts, are not cheap either. So diet is a really complicated thing. And I tend not to be quite as dogmatic about diet for that reason as I am about some of the other treatments that we recommend. Sorry to have such a long-winded answer to that question.
That's fine. You said the evidence is strong for exercise. So, can you summarize the evidence of the advantages of exercise?
Again, most of the evidence to support exercise does come from observational studies. So you might say that it has similar limitations to the evidence for diet. There are some more randomized trials suggesting a benefit for exercise. But here's where I think exercise and diet differ. I don't see any particular downside to exercise. There is a modest risk of, having a cardiovascular event as a result of overly vigorous exercise. And of course, there are risks of injuring yourself during the course of an exercise. If you ride a bike, you can always get hit by a motor vehicle. But overall, the benefits, I think, of exercise are far more likely to outweigh those risks than is the case for any other treatment. And so I think you would struggle to find many physicians who would argue against moderate exercise, at least, as part of everyone's healthcare strategy.
I hear you. So, Jim, is there anything from the chat room?
Yeah, we've got a question from the audience that relates to ADT. Is there any physiological reason why an antagonist would be safer than an agonist?
Yeah, great question. There has been some research into it. A friend of mine, Dr. Pinthas, who's a urologist here in Hamilton, has taken a group of mice and given some of them ADT with luprolide and another group of them ADT with degarelix, and found that the group that got the luprolide as a GnRH agonist had more plaque in their big blood vessel, the aorta, than the degarelix group, and more markers of inflammation in that plaque than the degarelix group of mice. And what Dr. Pinthas has postulated is that it could be related to differences in FSH and LH levels, because we know that GnRH agonists over time tend to result in somewhat higher LH and FSH levels in the circulation than GnRH antagonists. Another theory is that perhaps, as you know, with a GnRH agonist, there's often an initial surge of testosterone before testosterone suppression. And perhaps that initial surge in testosterone does something to the cholesterol plaques in blood vessels. And another theory is that there may be receptors for this GnRH antagonist, or agonist, I should say, on the actual cells within the blood vessel wall that by stimulating them can have differential effects on cholesterol plaques within blood vessel walls. So those are the three main theories that are circulating as to why there could be cardiovascular differences between agonists and antagonists. At this stage, I don't think we have again, we don't have a lot of confidence as to what the answer might be.
Thank you.
Sorry.
We had another question on diet, which we might as well address here since we're so close to the topic. Is dairy a high risk factor for CVD? If so, what is a good alternative?
It used to be stated that dairy was a cardiovascular risk factor. I think the consensus is now that it has been overstated. And I don't think dairy is a very strong risk factor for cardiovascular disease, with the caveat that too much of probably any food is actually harmful to you. You know, if you drink too much water, it will actually upset your electrolyte balance and be harmful to you, even though we all think of water as being completely benign. So too much of anything, dairy included, is probably not a good thing, but certainly in moderation, dairy, from my understanding of the evidence and literature, is unlikely to contribute or accelerate a premature death.
Thank you.
Okay, you sort of hinted at this a little bit, but Dr. Mark Moyat at the University of Michigan is often pushing the idea of almost like a super pill that he would recommend for any man, whether the man had prostate cancer or not. And the components of his recommendation are that baby aspirin, metformin, and let's see, what else am I forgetting? And statins. And I just wonder, do you think that that's a good idea, or is that overboard to offer this to any man?
You know, this is an idea that's been bandied about for quite some time now. I think as early as, it must be decades ago, that Dr. Ward and Dr. Law in the British Medical Journal actually proposed a so-called poly pill that could be taken by everyone, let's say above a certain age, to prevent cardiovascular disease. And this has actually been tested. So a recent trial conducted by our institution suggested that a poly pill with a number of these sorts of components in it could be very effective at reducing the risk of cardiovascular disease. I think it's attractive because it's simple, right? Instead of taking 4 or 5 different pills a day, you're just taking one a day. The main downside to this approach is it may be a little more difficult to adjust things. So let's say, for instance, you had a history of a stomach ulcer and you didn't want to take aspirin. You can't just take the aspirin out of one of these poly pills. It's built in there. Now, the counter argument to that might be, well, maybe there's going to be a range of different poly pills with different ingredients that can be taken off the shelf, and you just get prescribed the one that is best suited to your characteristics. And I think that would be a really nice goal to have. A practical limitation to that, unfortunately, is that pharmaceutical companies do not have a strong interest in developing polypills at this stage, because unfortunately, and this is the cynic's view of it all, many of the drugs that would go into a polypill and that have been shown to be beneficial for many patients in general are off patent. So they're generic drugs, and therefore they don't cost a lot of money, and therefore pharmaceutical companies don't stand to make a lot of profit from developing these compounds further. And that's, you know, one of the, in my opinion, the real shames about our healthcare system and the way that drugs get developed. But be that as it may, there are still people trying to push this polypill concept forward, and I hope that it gains some traction because I think there's some value in it.
You know, you had talked about metformin versus some of these newer agents. Metformin is relatively cheap. You know, personally, I took metformin and I saw my PSA go down. And, you know, I had talked to my urologist about it, and he said, yeah, it seems that the research indicates that that it will have a beneficial effect. And there's some research in mice that there's increased longevity for mice. So that's good news for the mice anyway. But you were suggesting these other medicines, and I imagine, at least in the US, they would be pretty expensive. And I wonder if there's that much of an advantage with the newer medicines over metformin.
Yeah, it's a very good question. Because of their, I guess, when these drugs have come onto the market, when they've been developed, we may never actually get an idea, the answer to that specific question, which of these drugs are better. It's just not a head-to-head competition that is, I think, ever likely to get funded. What's probably more realistic is that if you have diabetes, you'll end up on both of them. Because, to be honest, neither of them is particularly that powerful at reducing blood glucose levels, not as powerful as, let's say, insulin. But, as you mentioned, they may both have beneficial effects. I think that the quality of the evidence to suggest that for these new drugs, these SGLT2 inhibitors, is very robust and very strong, especially for individuals who do have known vascular disease. And that's not to say that metformin is not also effective, but if you had to pick one over the other, that's a tough call. I don't think we have good enough research to tell us which one you would pick. If I were a patient with diabetes and I could only have one of them, to be honest with you, based on the evidence that I've seen, I would personally pick an SGLT2 inhibitor. But as you mentioned, Howard, I think cost has to be a factor as well. Eventually, these SGLT2 inhibitors, and it's not that far away, will come off patent, and then the cost of them will come down as generics do get manufactured. And then I think the playing field will be much more level, and these drugs will be available to benefit more people.
Can you explain why these medicines for diabetes have a beneficial effect with prostate cancer?
Do you mean metformin or SGLT2 inhibitors?
But either one of them, I mean, both of those seem to affect blood glucose. So is there a connection to prostate cancer?
So first of all, I don't think there's any direct evidence that SGLT2 inhibitors are specifically beneficial for prostate cancer. So I'm thinking more in terms of cardiovascular protection and benefit. That's where in the general population, these drugs have been shown to be effective. For metformin, both in people with and without prostate cancer, that's been well shown to increase something we call insulin sensitivity, because resistance to this hormone insulin is what helps to regulate blood sugar levels, and resistance to insulin leads to high sugar levels and all the complications of diabetes. Metformin has been well shown to increase insulin sensitivity, and so that's why it's regarded as a good way of overcoming some of the metabolic problems that diabetes is associated with. As to how metformin might actually be beneficial on the prostate cancer itself, I'm not certain about it. I think that really, again, there have been a number of smaller studies, but I'm unaware of any large-scale study that's shown that, let's say, the risk of developing metastatic prostate cancer is reduced by the use of metformin. But I'd have to defer here to one of my uro-oncologic colleagues who may know more about metformin and prostate cancer than me.
I'd like to throw something in. It's out of the chat room, and it relates to something else I know you wanted to talk about. The question is about testosterone replacement. Is it on topic unless it's related to cardiovascular risk? So, maybe you can talk about, what the significance to prostate disease is from testosterone, as well as cardiovascular disease. But I think it might be a good time for you to talk about how this might all tie in with COVID. if you know what I mean in terms of
Yeah, no,
testosterone.
I appreciate that segue there, Howard. And maybe I can go back to front and start with testosterone and COVID first, because as you know, this is a real interest of mine, and we're applying for funding to explore this question further. What is known is that men are about 50 to 70% more likely to get COVID than women, and men seem to have a worse outcome from COVID, higher chance of dying than women. And so people have naturally wondered, well, is it the testosterone? Is it doing something to men that makes us more predisposed to getting COVID? As it turns out, one of the molecules on the surface of your lung tissues that is important, it seems, for COVID entering the lung tissue is actually driven by testosterone. And so we know in humans that this molecule is increased with higher testosterone levels. And in animal models, if you cut off the testosterone, it downregulates the expression of this molecule. And so this has further increased people's suspicion that testosterone may play a role in predisposing folks to getting COVID. To put more fuel on the fire, there was a big study out of Italy which looked at men with prostate cancer, divided them into those who were on and versus were not on androgen deprivation therapy. And of course, those on ADT, we assume had zero or pretty close to it testosterone. They found that folks on ADT had a substantially lower risk of getting COVID than people who were not on ADT. And so again, that really, as I said, added fuel to the fire. Now, there was subsequent study from Ohio showing that in fact there may not have been any association in their experience between ADT use in men and the risk of getting COVID. So there's still some uncertainty here, and we really need more research to understand whether low testosterone really is protective, or the opposite, whether higher testosterone levels increase your risk of getting COVID. And so that's what we're asking for funding from the Canadian government to do, is study this research question. And so that's my take on testosterone and COVID. In terms of other...
Yeah, let me mention, I'm going to put a plug in here. You're hoping also to get support from patients who, oops, that should be Jennifer. And this has this email address. So anybody who wants to write a note in support of Darryl's research, he would appreciate it. And is that also a good contact for you, Darryl?
Absolutely. I can certainly provide the email address of our research team. And if you feel as if this is a good idea, and I know I've circulated to you, Howard, a summary, I think, of this proposal we have. If it sounds like a good idea and you think it's worthwhile, any notes of support from any anyone really in the community who's affected by this is valuable to help convince the grant reviewers that maybe it is a good idea.
So I'm going to put a plug in here for you too.
I can just unshare my screen there. And oh, great, terrific! I see you've you put that there in the chat box. That's terrific. Thanks for that, Howard.
So, but you know, in terms of, it's not an exact connection, but the question was talking about testosterone replacement and cardiovascular disease risks. Is there a prostate connection to any of this?
Yeah, it's a really complicated and difficult question. I think it's best thought of by dividing it into the two groups, you know, folks with and without prostate cancer. I think in the slides, we kind of addressed, you know, testosterone suppression and the risks of cardiovascular disease a little bit in folks with prostate cancer, but it's also interesting to look actually at the general population without prostate cancer and trying to understand what effects testosterone has. It has been shown that low testosterone levels in folks, you know, from the general population, so without prostate cancer, is associated with higher rates of obesity, of high triglyceride levels, higher risk of diabetes, and high blood pressure. there have been trials to see whether replacing testosterone in folks, men especially, with low or borderline low testosterone levels is beneficial. And what those trials can show is that replacing testosterone can improve things like muscle strength, can improve glycemic indicators, as I mentioned before. But what hasn't ever been proven is that replacing testosterone in testosterone deficient men actually reduces the risk of a heart attack or a stroke. And so we don't have enough research evidence to suggest to us that folks with low testosterone necessarily should have it replaced. And of course, if you've got or had a prostate cancer, then you do have to be mindful that testosterone is obviously what drives the cancer. So certainly, I wouldn't be advocating for testosterone replacement in anyone with their past history of prostate cancer.
Okay. Jim, any other questions in the chat?
I've got a question on muscle strength and exercise. You said that it's recently been discovered that muscle strength itself is a risk factor in CVD. What does that mean in relationship to the recommendation for moderate exercise? Should you be adding in weight training? Should your moderate exercise be weight bearing, or how does it all fit together, I guess is what I'm saying.
Yeah, great question. So I first got interested in muscle strength with an analysis of a study of about 140,000 or so adults from many countries around the world. And what we did was measured their muscle strength about 8 years previously, so 8 years ago or so. And we just measured muscle strength really simply with using a device called a hand grip dynamometer, where you just squeeze this device as hard as you can, and it tells us how strong your hand grip is in kilograms or pounds. Now, even though it's just your hand, we're not saying that you need strong hands necessarily, because the strength of your hand grip is actually correlated with the strength of other muscles in the body. And what we found was that the stronger your hand grip is, just a marker of general muscle strength, the lower your risk of developing heart attacks and dying of cardiovascular disease over the next 8 years. And so this really for us said that, look, muscle strength may be an important and modifiable risk factor for cardiovascular disease, or low muscle strength might be an important modifiable risk factor. And so to your point, I do believe that part of every exercise regimen should include some resistance and strength training, as well as more aerobic cardiovascular exercise. And this is particularly important, as you know, in folks getting ADT, because the loss of testosterone will lead to a reduction in muscle strength. Many men whom I see as patients who are on ADT find it very difficult to regain that muscle strength. And I think really the best thing to do is to try and really focus on sort of maintaining resistance training as part of your exercise if you are initiating ADT.
Yeah, let me remind the audience, if you have questions, please put them into the chat. We have about 15 minutes more, and so we have time. We'll have time to get to you. I got an email question from somebody. It sounds personal, but maybe there's some general information that you could extract from it, Darryl. This man has a partial blood clot in his left thigh, probably due to ADT mets, according to him. He was put on, and I don't know how to pronounce this drug. Is it Eliquis? For 1 year. The clot resolved after 2 months. And then, due to his primary care doctor's concern about possible bleeding side effects, he was instructed to discontinue taking that drug. We can't practice medicine here, but he says, but maybe you can give a generalized reaction, or which is, should I have continued on Eliquis as a preventative of potential additional blood clots forming? So, I don't know what you can say, but whatever you feel comfortable.
No, I think you make a good point, Howard. You know, we obviously can't give specific medical advice here, but what I would say is this: if you've had a clot in the veins in the lower leg, so this is called deep vein thrombosis or DVT, we often think of it as one of two types. One type is not associated or not related to cancers. So typical example is people who have fractured their leg because of a motor vehicle accident or you know, any other reason, who've been immobilized and developed the blood clot that way. And in those people, it would seem very reasonable if there's a clear reason for the clot, that once the reason has gone and the leg is mended and you're no longer immobilized, that the blood thinner stops at a certain point. Cancer is a different beast, because cancers do seem to release molecules when it's present in the body that predispose to blood clotting. And for many cancer-associated deep vein thromboses, we would not necessarily stop a blood thinner. Now, prostate cancer is, again, you know, there's a lot of nuance, which is why we can't give specific medical advice. Because if you've had, let's say, prostate cancer or some other cancer very successfully treated, it's, you know, been more than 5 years since, for example, the cancer was resected. One might argue that, in fact, you're cured of that cancer. There's no evidence that you have cancer in your body. And so perhaps the blood clot was unrelated to the cancer. It was just a spontaneous deep vein thrombosis. And so all of these nuances make it a very individualized decision-making as to how long a blood thinner should be continued, or if it should continue lifelong for someone who's had a deep vein thrombosis.
Okay.
We had a question in the chat room on aspirin, and the question was that if somebody has been on aspirin for a long time, 30 years, for example, taking 81 milligrams, what's the best way for them to stop if it doesn't really have a benefit? Should they stop completely, just cold turkey, or taper off? What's the recommendation?
And Darryl, is there a difference between people who've had a cardiac event versus those who haven't? It's, you know, I read that question, and the person who asked it doesn't make that distinction. So I'm asking you, you know, is there different advice for those who've had a heart attack versus those who haven't?
That's a critical point, I think, Howard. So a really good point. So first of all, I would be reluctant to stop any medication without consulting your physician, because as we mentioned for the previous question, you know, there are nuances that only somebody who's familiar with your individual healthcare issues could advise on. That said, it is, I think, correct to say that people with a history of cardiovascular disease, and that includes people who've had heart attacks, many kinds of stroke, coronary stents or bypass surgery, probably should be on aspirin. The large majority of people with one of those types of conditions should be on some form of blood thinner, and aspirin is the most common. So that's the first thing. Someone who has not got any history of cardiovascular disease, so they've not had bypass surgery, no stents, no heart attacks, no angina, whether or not they should be on aspirin, like I said, is pretty controversial. And now it probably is not indicated for many such individuals. And so while the decision needs to be individualized, I have been advising many of my patients who take aspirin for that preventive type of role that they could consider stopping it because there does not appear to be a significant benefit in terms of life-saving in those individuals taking aspirin. As for how you can stop it, 81 milligrams is a really low dose. So I'm not sure there's any benefit in stepping it down to every second day. You know, I think that you could just as easily just stop it completely if that's what is felt appropriate to do by your physician.
Yeah, if I could throw something else in here too. I had a STEMI heart attack, which cardiologist called a widowmaker 16 years ago. It should have killed me, but exercise saved me in the end. But I was put on 81 milligram baby aspirins. And about 2 years ago, my preventive cardiologist at the University of Chicago said, you know, nobody has actually ever proved that 2 is any better than 1. And so I enrolled in a study. I don't know how big the study was, but so I cut down from two a day to 1 a day. So I mean, what do you think about that, 2 versus 1, for somebody who's had a heart attack?
Look, I would agree with your cardiologist. I'm not aware that taking 2 a day instead of 1 does any better for your heart than taking 1 a day. In fact, what is known is that taking 2 a day or more increases your risk of stomach ulcers and bleeding. So I think that going to 1 a day is what I would advise many of my patients under those sort of circumstances. I agree.
So Jim, anything more on your side there?
I've got a couple things. I think maybe the first one is just a clarification where I may have misinterpreted the question. Is there any special benefit to weight-bearing exercise? I mean, is that something that really needs to be part of a CVD risk prevention regime?
Look, I think weight-bearing exercise is great because of a number of reasons. Look, the simple effect of gravity on the bones is what helps to keep bones in pretty good strength. Same reason that astronauts who don't have the benefit of gravity for a long period of time will have clear weakening of their bones by the time they get back to Earth. So I think in principle and in practice, weight-bearing exercise is terrific. There are some practical limitations that many of this audience might be familiar with to that. And that is if you've got significant bony pain, be it from metastatic disease, be it from arthritis, whatever the reason, weight-bearing exercise may not be that simple. Another situation actually we commonly see in our prostate cancer patients is urinary incontinence after they've had a definitive therapy for their prostate cancer. And again, a lot of folks will find that doing things that are weight-bearing, like jogging especially, or even walking, can cause urinary leakage, which is obviously, can be unpleasant and undesirable. And so with those caveats, I encourage my patients to undertake weight-bearing exercise. If it's really not possible because of, joint pain or bony pain, then certainly I think pool-based exercises are good because the resistance of the water as you're trying to get through the pool, or if you can swim even better, is also, I think, a good way of maintaining strength and also fitness.
We had another question, which I'll just read it. Are there studies correlating age with risk factors? Meaning, as one gets older, should we concentrate on different factors?
Yeah, great question. The strongest predictor of death is your age, unfortunately. And age is also correlated, as you allude to, with cardiovascular risk factors. Probably the clearest example is in hardening of the arteries. As you get older, for a variety of reasons, things like high blood pressure included, the arteries tend to harden. We think there's this phenomenon of aging of the blood vessels, so vascular aging, where on the one hand, they get, because of this sort of hardening process, more predisposed to forming those sort of plaques and clots I showed you in the slides, and therefore of causing things like angina, like heart attacks and strokes, etc. But also because the arteries are older, they're also prone to bleeding if the artery gets disrupted in any way. And so you really have a two-edged sword there because you're prone to both clotting in an artery as well as to bleeding. And it's what often poses a big challenge for folks as they get older, is that we would like to use blood thinners like aspirin to stop heart disease from coming back in folks, but they're also having bleeding issues, makes it very difficult to use blood thinners. And that's probably the best example, I think, of how risk factors can change with age. All of the other risk factors, or many of them that we've talked about, also deteriorate with age. So the risk of diabetes does tend to increase with age. The risk of a whole lot of things, including cancers, increases with age. And it's unfortunate, as I said, I think during the talk, it's one of the certainties of life is that with old age, unfortunately, does come death. But I think there are things we can do to modify it. And many of the modification of risk factors that we've mentioned in the slides, I think can contribute to sort of prolonging life and at least slowing down some of the processes associated with aging.
Okay.
Thank you.
Let's see, I saw another question in there. Ooh. Okay. Can you comment on estrogen therapy versus LHRH?
Yeah, that's a tough question. I could perhaps comment a little on cardiovascular differences. Most of the evidence implicating androgen deprivation therapy, or so should we say hormonal therapy as a bigger umbrella in cardiovascular risk, is really from the LHRH agonists. There's not really so much evidence that I'm aware of about estrogen in that space. Now, I don't think I'm the right person to comment on estrogen's role in treating a prostate cancer. That's probably best left to a uro-oncologist. So it's probably a little unsatisfactory and unsatisfying, I should say, as a response. But I just think that the association between estrogen and cardiovascular events is less clear than it seems to be for LHRH agonists.
Howard, can I just clarify that? I think the real question is that originally one of the reasons that the FDA never approved estradiol was because they felt that it led to an increase in stroke risk, clot risk, and that if you took the estradiol by a patch as opposed to a pill or however else it was, I don't know how it was otherwise given, that you reduce that risk. And I guess what the question is what is your opinion of estrogen therapy in terms of heightening CVD risk?
Yeah, it's a good question. Actually, probably the best evidence comes from women, and that's a natural experiment in that, as you would appreciate, women have higher estrogen levels than men, at least premenopausally. And during all that time, their cardiovascular disease risk is lower than men. Now, whether or not the higher estrogen levels in women is the cause or reason why they have less cardiovascular disease than men premenopausally is really uncertain. What is known is that postmenopausally, there was a big trend to use hormone replacement therapy in women, not just for relief of menopausal symptoms, but because there was, again, this observational data that women who happened to be taking estrogen replacement seemed to have a lower cardiovascular disease risk than women postmenopausally who did not take estrogen. But because this was observational data, and we've spoken about some of the limitations of observational data, a couple of large clinical trials were done to see if hormone replacement therapy in postmenopausal women did in fact reduce cardiovascular disease rates and clotting rates compared to no hormonal therapy, no estrogen replacement therapy, I should say. And what those trials found was that in fact, it was neutral. It didn't seem to have an effect. And in fact, one trial actually suggested, as you did, that it may increase the risk of certain cardiovascular events if it's actually given as a replacement in estrogen deficient women. So I think that there is this potential signal that giving estrogen exogenously may not be the best thing from a clotting, especially a venous thrombosis point of view. And so I agree, it's certainly something that I would not necessarily advocate either, especially when there are other alternatives, shall we say.
Thank you.
The thing I've observed about a lot of the men on active surveillance, and it may be true with other men with prostate cancer, is many of them have almost a religious belief in diet, a particular diet. A lot of plant protein people, vegan, vegetarian, and these people are convinced that they found the solution for everybody, or at least for themselves. And well, what is your perspective on all these different diets? I mean, it seems like a diet book becomes a bestseller every year, and the next thing you know, people are off and running. Is there a lot of faddist behavior here, or what's your take?
Absolutely. I'm always astounded in the diet and nutrition world about how strident and opinionated many people are. But when you look at the quality of the science and the evidence that is used to back up what they're claiming, it's actually really modest. And to be quite frank, a lot of the times it's weak. And so in general, my approach is if somebody wants to try a particular diet, unless it's very clearly harmful, like, an all junk food diet, I don't have any strong objection, because I think that many diets are unlikely to cause substantial harm. But I do advise patients that I think that the evidence to suggest that such a diet is likely to help their health is pretty modest. And in most cases, I think they could save themselves a lot of money and enjoy life a little bit more if they had a more liberal and less restrictive diet. So I think for me, the guiding principles when I have to give dietary recommendations are to generally have everything, including alcohol, in moderation. And if you have to encourage particular foods, like I mentioned, I think in the talk, I do encourage, more consumption of fresh fruit, vegetables, unprocessed foods, I think is very important. Some amount of lean meat is also a good thing if you're not vegetarian. And I would try and discourage too much processed foods, because it seems as if processed foods is likely to be harmful. Would discourage too much carbohydrates, and especially refined carbohydrates and refined sugars. And so, that is just broad principles of what I tend to advise my patients.
Well, another hot area of discussion are dietary supplements. In the prostate cancer world, a lot of people are taking this and that, mushroom extracts, that sort of thing. Do you have the same skepticism about supplements?
I do. And I think the reason why is that, folks at our institute, not myself, have done a number of clinical trials to look at the benefits of various vitamins, be it vitamin E, vitamin D, all these sorts of vitamins, and none of them have shown any strong signal of any benefit at all. And the truth is that for most people with the sort of diet I described before, living in North America, you're going to get enough dietary vitamins and nutrients to meet all of your body's needs. And any extra that you take in through a capsule, you're probably just going to pee out. And so, again, if some of my patients want to take vitamins, I don't have any strong objection to it, because like I said, most of them are just excreted if they're more than what your body needs. But I do let them know that I think that they could save themselves some money and probably put it to better use than necessarily buying supplements. And so that's my general approach to vitamins and supplements. Now, obviously, there are people with specific exceptions to that. For instance, some people with pernicious anemia will get vitamin B12 deficiency. So there are specific medical examples where that is not true. But for the general individual with no underlying sort of disease that leads to malabsorption of vitamins, I'm not sure there's any real evidence that taking supplements is that beneficial.
Well, I think we're about to call it a wrap. And so just want to thank you for the time and enlightening us about cardiovascular risks and how men with prostate cancer ought to be paying attention to them. I want to remind people that we'll have our regular call-in meeting in a week, 8 p.m. Eastern time, same station. If you can write a note to Elliot Kerman, that would be appreciated as he's recuperating. And if you can give Darryl's research a boost, I know he'd appreciate it. So I think that's about it. Any final words, Joe?
Well, I think we had a very good session. So Darryl, thank you very much. And Howard, for helping to drive it with Jim's assistance there. And we got a lot of good questions, a lot of good response. And I know we always have trouble getting the exact count, but I had about 63 attendees. So I think that's not too bad, not too bad. So thanks very much.
Well, thanks very much for having me. It's a pleasure.
Thank you, Darryl.
Thank you
Okay,
very
folks.
much, Darryl.
Well, I'll just ask my team to hang back behind, and the rest we can say, have a good night.
Good night, everyone. Take care.
Good
Take
night.
care. Thanks again.
Thank you.
Thank you.
And by the way, Joe, the highest number I saw was 65.
Yeah, somehow the count varies, and I'm the one that opened the room, so I don't know. But I'm helping some of the folks
Depart.